Good afternoon. We have the second speaker today, Dr. Suhail Ahmed, who is presently the senior surgical oncologist at Venkataeswara Hospital. Now we'll be talking a very important topic which a general practitioner must know. What are the symptoms of cancer a GP should know and aware of? Coming to Dr. Suhail Ahmed, he hails from a family of surgeons and has special interest in surgeries from his undergraduate days. After completion of his undergraduation from the renowned Sri Ramchandra Medical College and Research Institute, he joined the prestigious Southern Railway Headquarters Hospital where he developed his surgical skills. Dr. Suhail is also a faculty at the Karpagaranar Medical Institute Sciences. While at Railway Hospital, he acquired dual degree in general surgery, DPhD from the National Board of Examination of New Delhi and MRCS from the Royal College of Surgeons, Edinburgh. He is currently focusing on spreading cancer awareness and cancer prevention among people. He is working to make cancer treatment affordable and available to all. Another area of his interest is cancer screening and high risk and familial cancer patients. He performs very novel surgical procedures in oncology, which includes laparoscopic surgery for thoracic, gastrointestinal and gynecological cancer, breast conservative surgery, sentinel node biopsy for breast cancer, fertility preserving surgeries for gynecological cancer in young women, and a few other high-tech surgeries like hyperthermic intraperitoneal chemotherapy for advanced gastrointestinal and gynecological cancer, and limb salvage surgeries for soft tissue and bone cancers. Over to Suhail Ahmed, sir. Welcome, sir.
Thank you, sir. That was a very vivid introduction, and so I'm actually very stressed. Madam's talk was excellent. She's raised the bar really high, so I have to match to her level. And I should make sure none of you all sleep.
You have under the mic, just one speaker there.
And I'll have to make sure nobody sleeps. I have to keep everybody alert. So that bonus is on me.
Surgeons always do that.
I've tried my best. Let's hope it works out well. So I'm gonna stick to my topic, symptoms of cancer, because this is something everybody needs to pay a lot of attention to. Surgeries, yes, we will discuss in the end, but I will talk on very specific surgeries that you want to hear about from me. First, a big bow to all of you for coming here on a Sunday afternoon, because of course for all of us there are better things to do. Family, everybody, all the kids in the house will want you not to go out on a Sunday, including my son, but really a big bow to all of you for coming here, sharing your knowledge and wanting to learn new things. I'd like to know the spectrum of the audience here. How many of you all are specialists? How many of you all are physicians, general practitioners? What group are we dealing with here? Mostly general practitioners. Another big bow to you because your knowledge is, like the best. With time, all of us go to specialty and slowly we start forgetting our basics. I can talk about oncology for days together, but you ask me what is the current protocol in treating tuberculosis, I'll be like, I have to discuss with a fellow physician of mine.
GP has width, but
exactly.
That is specialists are depth.
Yes, but again, yes, we do have depth, but our group of patients we treat is a small group, sir. So that way, a real big bow to you all. Because second thing is you are the first people to see a patient and you are the ones who start the treatment and then refer them to the concerned specialist. So that way you guys are doing an excellent job in the community. And when I come out of the hospital that I practice in, I prefer to call myself as a community doctor rather than a super specialist, because
you're called family doctor.
Family doctors. I want to call myself as a community doctor because I want to be available to the community. Anybody should be free enough to come and walk up to me and ask anything regarding my specialty. I want to make myself available. That's the whole point. So let's start with this. The next slide, please do not get offended. The reason I'm telling you not to get offended is because all the people there who have been blindfolded are wearing a doctor's coat. Okay, so this is not just any person, not the status of a doctor in the rural setup or urban setup or anywhere, even in tertiary care center, you will come across a patient where you'll have this feeling. At least one patient a day. In a high volume set, at least one patient a day, you will come across where you'll have this feeling, oh my God, what am I dealing with? Is it this? Could it be that? This is where you take the help of your colleagues to find out. Everybody together will form a piece of the puzzle, and in the end, things will be sorted out. So this is our state. About 10% of patients in oncology are like this. I can quote a lot of examples. In fact, I have some interesting scenarios. We'll go to that, you'll understand what I mean. Okay? So the question is, why are we discussing this? All of us have an idea. Okay, right. A person comes with a breast lump, very likely breast cancer. 99% breast cancer in a middle-aged person or even younger age groups these days. You examine the patient, you have an idea. So in that situation, why are we talking about these symptoms? Everybody knows something about everything. So what is the purpose of the discussion? The other 1% patient with the breast cancer will not come with a breast lump. They'll come with an axillary node or a breathing difficulty or something like that. Okay, the tumor might be small, 1 centimeter. The patient may not have seen it at all, but patient will come in a metastatic setting. So this is the idea of this discussion or this lecture today. To look for atypical symptoms, some things that we may have not even thought about, not overlooked. That's a different thing. Not even thought about. A diagnostic surprise. Let's go to the case scenarios. This is going to keep you up for some time. Now this, I want it to be a two-sided conversation. Throw the ball. Let's see if I can hit it. A 68-year-old teacher, Mrs. X, a breast cancer survivor for 20 years. She's been absolutely fine, operated, received chemotherapy, received radiation, on hormonal treatment, completed for 8 years, on regular follow-up. Whether she forgets to celebrate Diwali or Pongal or not, she doesn't forget to meet her oncologist for 20 years almost. So for the last 1 month, she complains of staggering of feet and fear of missing steps. This has been going on for the last 1 month and it has been progressive. So she says, I had this fear of climbing stairs, so I started taking the lift. Now I'm having trouble even walking on plane 4. I have a feeling I'm not able to perceive depth. I have a feeling I might fall. So what do you think is happening here?
Secondaries in the brain.
Okay. So yes, most of us think of something like this. She had actually met some friends of hers, medical friends of hers. She was being given basic treatment. So now coming from an oncologist, you think of a metastasis. But if this patient had walked into your clinic, would that have been your first thought?
Imbalance.
With the same history, somebody who's a 20-year-old breast cancer survivor, would that have been your first thought? What if it was metastasis?
The possibility is high.
Possibility is there.
What I go was
Correct. So that will be your first thought. Okay, so you'll want to treat the patient with something small to start with. That's what happened with this patient also, but eventually turned out to be something else. So this is something we have to deal with. Just because she comes with giddiness, you can't send her straight away on the first visit for an MRI brain. Okay? Neither will the patient accept it. At some point, we'll also feel bad. Okay, we'll want to be careful, but at the same time, we'll also want to be cost effective. The second reason where things go wrong is sometimes patients don't even come back to us. If they're not happy, okay, who's the next person? Or it's an emergency at night, they go to the close by hospital. So a lot of mishap like this happen.
doctor shopping.
Yeah. So this is a representative image not belonging to that patient. In fact, that patient's lesion was somewhere near the occipital region, close to cerebellum. That's why she developed the staggering pain. Okay, so she had something like this. It was met after 20 years. Anyways, she was diagnosed, radiated. She's doing fine now on follow-up. Second patient, 24-year-old male medical representative. He had back pain for 3 months. Being a medical representative, he self-medicated himself. 3 months, back pain, he was okay. He thought he was probably overworking, that's why there was the back pain. So after 3 months, he started developing symptoms of acid peptic disease. Then he thought, okay, maybe because I took too many painkillers, I'm having gastritis. but then he approached a doctor and he was given treatment for acid peptic disease. 1 month later, he developed a cervical node, left supraclavicular node. Again, he went to another specialist. He was treated for that, suspected tuberculosis. But then at one point they said, okay, let's evaluate this. So they did an FNAC of the node. They found out it was a metastatic adenocarcinoma. So directly stage 4.
Primary.
Okay. Primary was in the stomach. Okay, so he had back pain. It was a posterior wall growth infiltrating the nerves posteriorly. That was his back pain. Then as it started growing, he developed symptoms of acid peptic disease, and then he developed cervical node. All within 6 months in a 24-year-old person.
Is it so common, sir, in younger age? 24.
Not very common, sir. But what we have to understand is, in this age, it's very aggressive. This is how they come. 7 months, everything has got over. Yeah. Whatever be the reason, it is aggressive in this age. H. pylori or whatever be the reason, it is aggressive in this age. So in this patient, how many of us would have actually wanted to get him evaluated? When in the first 3 months when he came with back pain, what could have we thought of?
Maybe two-wheeler.
All those things. A lot of physical stress, physical job, running around, that we were attributed to that.
Two-wheeler driving.
Yeah, two-wheeler driving, everything. Okay. Acid peptic disease, yes, at some point somebody should have been vigilant to find out, okay, youngster. Okay, medical history is that he's been taking painkillers, but still 3 months he's not settling down. Let's put in the scope. Somebody should have thought of that. So somebody would have also thought of that. Probably if he had visited that person for the second time, telling, I'm not doing okay.
Yes.
Most of us think of that. Provided patient comes back to us telling, boss, your treatment didn't suit me. How do I go about it? Next patient, 72-year-old lady. A fairly reasonably well-built lady, somebody who takes care of herself, who takes care of her jobs. She can take care of herself, she does her duties. So she complains of loss of weight and abdominal pain for 6 months duration on and off. She lives in a joint family. So people thought, okay, initially maybe because of old age, let her take some rest, some dietary issues, some medicines here and there. Then 6 months later, she starts vomiting. Again, by then she started becoming a little weak, so she didn't go out of the house much, mostly bedridden. She was given medications for vomiting, but things didn't settle down much. By then she also started losing weight, almost stopped eating, went to liquid diet. She developed jaundice.
Primary, the colon, secondary in the liver?
Yeah, something like that, but not the colon. Yeah, so at least one thing we are sure, it's malignancy, right? Seeing the history, we are sure, okay, something is progressing, not good. So the patient, then she was admitted, she went to the hospital straight, she was admitted for jaundice, evaluated. First thing done was a CT scan directly by the physician whoever saw her in the hospital. So they found a large mass in the stomach, extending up to the duodenum, up to the D2, partly obstructing the ampulla, dilated systems. She's also got a portal node which is causing dilated intrahepatic radicals. Her jaundice bilirubin levels during admission were 20. Okay, so there's nothing to be done for this lady, poor thing. Frail lady. By when she reached the hospital, she was very frail. Given on palliative chemotherapy, that's it. She didn't last for more than a week. Okay, palliative chemotherapy was only oral capecitabine, nothing more than that. Oncologist said, no, let her go in peace. Let's not do anything active. Next case. So what happened there was, probably, her age was a confounding factor. People thought it was just old age that, she started developing some symptoms. Some symptoms are probably ignored also.
So are you suggesting that any patient who comes with any of these odd symptoms, you must investigate for cause?
No, that is where you have to use your clinical acumen, sir. That is where you score over us as general practitioners. Okay, you so many years of experience in so many patients a day, you guys can actually pick up when somebody is not doing okay, you guys can pick up. Okay, that okay, this is not usual. I have seen professors of mine who'll see a patient walk into the OP, from his cough, they'll say, dude, this guy got tuberculosis, man. Put him, get him, work him up for tuberculosis. In most cases, it will be correct. Okay. I'm not saying go gung-ho and investigate every patient with the atypical symptom, but at least keep them in mind. Okay, this patient comes next time, I had this trouble. Usually, I have this habit. In my prescription paper, I make a note. This guy comes back next time, I'm sending for an endoscopy. So even if he's fine next time he comes back, I try to ask him the same question 2 or 3 times. I'm not convinced, boss, you go for a scopy, that's it. Nothing in between, nothing less, nothing more. Okay? Even if he says, I am absolutely fine, nothing, no symptoms now, I said, you get this done or don't come back to me. I want to see you with a report, that's it. Okay? As rude as it might sound, we have picked up 1 or 2 patients whom that first hunch that you get when you see a patient, that's very important, sir. That takes you places. And again, another hunch is that last patient that comes to you at the end of the day, 10 o'clock when you're shutting down your clinic, somebody will come in a hurry. That guy has a finding. Mostly that guy has a finding. It could be something very trivial also, but that guy will have a finding. That's why at the end of the day, he's running and coming to a clinic. So never ignore such cases. So this lady, 53-year-old lady, lower abdominal pain and constipation, on and off for 2 months, relieved with meds. She is somebody who had seen her, then had asked for an ultrasound. Ultrasound showed a 5x4 centimeter septate cyst in the right ovary, very hemorrhagic cyst, as per the radiologist. So whoever saw the patient said, okay, you be on follow-up. If there's any trouble, I'll give you some medicines. If there's any trouble, please come back. Let's see how we can work you on that. 2 months later, again she developed abdominal distension. So this time, she went to the same practitioner 3 consecutive days. Every day, according to that practitioner, the distension was obviously visible. First day mild, second day moderate, third day severe, to the extent that she is showing body orange in the abdominal skin. Okay, so she said, okay, you go for a CT scan, let's see what you're having. And CT scan showed large pelvic mass. Whatever was 5x4 centimeter then is now 18x12 centimeter. She's got gross ascites, liver is floating in a ascitic fluid, so gross. CA125 is 2500. This is her image, something like this. You can see the adnexal mass down there, and you can see the ascites there. Liver is somewhere in there. A scenario like this. So, actually nothing went wrong with this patient. Everything was fine. She was on regular follow-up. She went to the doctor. Doctor also did their part of the job. But sometimes there are misses like this. Nobody's fault. Okay. A good scan was done in a good center. Radiologist did confirm that there was nothing to worry about. It was just a hemorrhagic cyst. She had some vague symptoms. Nothing really to be complained about. But in the end, it turned out to be like this. Now she's on her chemotherapy now. She's responding well. Let's see how it goes. This is a very interesting case. Funny, something like one of our Tamil cinema scenes. So, 24-year-old girl, hospitalized, had abdominal distension for 2 months. Hospitalized, of course, most of these girls, they have some constipation, all those issues will be there. Most people lose weight when they go to hospital. Some people also gain weight. That's a different thing. So, this girl had abdominal distension for 2 months. She probably thought she was just gaining weight, so she ignored the fact. Then she went home. Parents noticed, okay, something is wrong. Your looks like you've started to gain weight. What is going on? Then she said, no, I'm okay, but I've been a little tired lately and my appetite has been a little low. Then they took her to the family physician, gynecologist. So she examined, she asked for the LMP. Patient said LMP is due for the last 2 months. I didn't have my periods for the last 2 months. Gynecologist didn't say anything. She said, just get an ultrasound and come back to me tomorrow. So it was late in the evening. She went home. The entire night there was drama at home. The mother kept crying, what did you do? Who's responsible for your pregnancy? That was the first line. You've not had period for 2 months. Your abdomen is growing. Who's responsible for your pregnancy? What did you do? The drama in their house the entire night, and all crying, beating, bashing, everything happened. Next day morning, they took the girl to the radiologist, as the gynec had suggested. Ultrasound showed this. She's got a germ cell tumor.
24 years.
24 years. She's got a germ cell tumor. And she came back. She got treated. She's doing fine now. Okay. So we see all kind of situations like this. This one is also a good one. 78-year-old male, right eye leg fossa pain for 2 months. So he was evaluated. Ultrasound showed something in the right eye leg fossa or appendicular mass probably. So whoever saw the patient said, okay, it's a mass, we'll put you on conservative management. Once things settle down, then we'll operate on you. Conservative management done. He also felt better. He underwent an appendicectomy. Histopathological specimen reported mucinous neoplasm of the appendix, and the base was positive for malignancy. Went back to the OT notes. The surgeon had promptly written somewhere there was some mucinous material found inside the appendix. Okay. So probably what would have happened was either the tumor would have perforated at the base or something, some mucinous material spilled out from the appendix. So it was a mucinous neoplasm of the appendix. Patient came back and, sorry, I did not have an image of that patient. Patient came back, we did a right hemicolectomy. Thankfully, there was nothing visible there. It was a low-grade lesion. So, this completion surgery sorted everything out for that gentleman. Take-home message here is, no matter how simple thing is, he's a 78-year-old. How often is an appendicitis in a gentleman of that age? So, that is something you need to think about. Okay. So everything was fine, but just one colonoscope inside or a CT scan may have, saved a lot of trouble for that patient. And a tumor marker, CEA was not done. CEA would have picked up something. Either way, the CEA was normal. So, but just it's a protocol, you have to do these things. Okay. Next patient, 62-year-old woman. Had symptoms of acid peptic disease. So basically she came to the doctor only for acid peptic disease that particular day. So she saw the surgeon's board there. So she said, after all this discussion was over, I have something else I need to tell you. The doctor said, what? So I've been having this breast lump in my left breast for the last 2 years. I said, that was actually the first thing you should have told me. Acid peptic disease is okay, that's something manageable. So she said, no, but don't worry about it. I think it's okay only because I've done a mammogram 3 times in the last 2 years. Both times it was BIRADS 3. So I was told it's good, nothing to be worried about. And the doctor said, have you got a biopsy done anytime? It's BIRAD 3, okay, but this age and you've been there. And the one important point she mentioned is, recently I feel my nipple is retracted. That's what lit a red lamp in the surgeon's brain. So, you've never got a biopsy done in the last 2 years? He said, no. They said it's BIRAD 3. He said, no need for biopsy. I said, okay, please get a biopsy done. No? Biopsy showed it was a carcinoma promptly. Okay, so there are people like this also. She knows, she's done her part. Okay, she's got mammogram done thrice. Probably this is only one half of the story. We don't know for the second half of the story. Somebody may have said get a biopsy done at least for a formality. Maybe, most likely it happens because now everybody is scared of cancers. Nobody just lets go of somebody like that. And the funny thing is she's got the mammogram done in 3 different places, met 3 different doctors. All 3 places are campsites. She got mammogram done in campsites because it was probably done free or at a lesser cost. So no follow-up after that. Just all 3 results are only for the mammogram. So this is her mammogram image. This one's also good. A 28-year-old IT employee had complaints of bleeding per rectum. 2 episodes in the last 6 months. Both lasted for a couple of days. Treated as hemorrhoids. Now he had severe abdominal pain in the right iliac fossa. He came to the hospital on one evening. So whoever saw him thought it was okay, it's definitely appendicitis, let's post him for surgery. But just prior to surgery, he thought, okay, let's get a CT scan done because evening time, no radiologist, let's get a CT done straight away. Thankfully, CT scan was done. Nobody went ahead with the surgery after just an ultrasound. CT scan was done, showed a cecal mass. Now, who really would expect a mass in a 28-year-old? Okay, and on the right side, he had bleeding. His symptoms are on the left side of his. Okay, so now he's come with the right iliac fossa pain and a mass in the and this is what we see. It's an adenocarcinoma of the cecum, 28-year-old. Then you start probing. Do you have any family history of malignancies? Then he promptly said, yes, one of my uncles had a colonic malignancy. He's no more, but that happened 20 years back. So, this is what happens. 58-year-old businessman, somebody who had a very active lifestyle. You know, he goes 2 international trips a year, goes around, drives a very posh car, solid lifestyle. He only wear branded clothes. You see him, he's like one of those film star kind of people. So he had fatigue for 2 months duration, weight loss and bony pain. He started self-medicating painkillers because he was too busy to sit down and take rest or think about what is going wrong in his life. He didn't even realize. Some of these people who have busy lifestyle now, by the time they even realize something is wrong, it would have been 2-3 months because they just keep running around. So for the last 1 month, he had decreased urine output. He has leg swelling. Then he thinks of going to a nephrologist. Nephrologist initially says maybe it's an acute kidney injury, but get yourself evaluated. One simple test. His urine routine showed casts. Some kind of cast. I'm not sure what kind of cast or what. He had renal failure. He had proper renal failure. Okay, he had this amyloid cast or something, some kind of cast that nephrologists see. He said, go get your skeletal survey done, get a PET CT done. He was found to have a multiple myeloma. The other test, everything on the M band, urine benzone protein, everything was positive and multiple myeloma. Underwent treatment for that. Okay, this is also an interesting one.
No, does multiple myeloma cause acute?
Yes, it causes one. That's what happens. It's a chronic situation only. But at one point, there develops acute situation where they'll reach the hospital. So invariably, the first line of thought will be an acute kidney injury. Then they will go to the reports. Then they'll relate it's a chronic change, not an acute change. So that was his diagnosis when he first saw the patient. That's an AKI, but it was actually a chronic thing only. Because his symptoms are also there for a month or more.
And longevity, sir?
Some of these people do well, some do horribly bad.
In spite of treatment.
In spite of treatment, yes. Depends on the stage.
How aggressive.
Okay, stage.
We have to do a lot of staging evaluation, skeletal survey, then they do inspiration.
So a long set of investigation.
Yes. From our colleague, we will tell.
So another 25-year-old IT employee had swelling in the region of thyroid for 3 years duration. So she was on regular follow-up. She got herself checked periodically, ultrasound, everything was done. Only thing that was not done there, because they said it was a thyroid stool, looked like a benign lesion. Only thing that was not done was a cytology. No FNAC was done. Then recently, when she actually met the doctor and this whole thing broke loose, she realized that there was a recent increase in size of the swelling. One. Second, she also noticed developing new swellings on the right side of the neck. So that is when this was the finding. Okay, you've got a left lobe of thyroid swelling, and in the right side you've got some nodes. So it's a papular thyroid, more on the left side than on the right side, but nodes are the contralateral side. So what went wrong with these patients? Some of them were easy and laid back. But a lot of them were still on follow-up. They were meeting somebody or the other. But in spite of that, there are nurses. So reasons for that is, one, from the patient's side, they don't go to the same doctor. That's been the history in 3 or 4 patients that we went around. Okay, so everybody wants quick treatment. You have a node in the neck. You go to a doctor. You want that node to get resolved. If it doesn't get resolved, they go to the next doctor. Anybody who sees a node will only think, okay, right, let's start an antibiotic. Maybe it's a reactive node. You go to the second doctor, he's going to think of the same thing. It's a reactive node. Let's give him a course of antibiotic. Okay. So in the meantime, what happens is this trouble starts growing. You don't even realize. You might keep thinking, if you remember that patient, I remember these weird patients. I remember these weird patients, they come for 1 year. Okay, because I have that thing. It might be normal only, but the attitude of the patient is what makes you remember that patient. Okay, so that's one trouble that happens. Second is atypical symptoms. You don't think of that something like that could be there. This is one thing. Atypical symptoms, you don't think that, okay, this symptom could actually lead to a malignancy. Because you see, at an average, any doctor who runs a clinic, who sits in the clinic, runs 2 sessions, will be seeing about 60 to 100 patients a day. Seeing so many patients, no, it's not easy to pick up an atypical symptom and keep that in mind and keep following it up. So the other reason, who do you think are our biggest competitors? Who are our biggest competitors?
The employee seeking a Google search.
So I told you, a person goes to one doctor first, then second doctor. Then what happens? Some of them are literally lost because they're stuck somewhere here. Okay, so the second doctor, we never see our colleagues as a competition. Most of us don't do that at least. Okay, our competition and the person that we actually need to save our patients from are these kind of people. This is only one more coming on now. WebMD. You put 3-4 symptoms together, 90% of their diagnosis will only be a cancer. Some cancer only.
Yes.
They come running to you. Their opening statement is, I think I have cancer. That is their opening statement when somebody comes into your clinic. Third, you have these people also. I am not against naturopathy. I am not at all against naturopathy. I think some of those other systems of medicine have excellent treatment for some diseases. Okay, but only thing is I do not know for which diseases. Second thing is I do not know where to send those patients. Okay, so who's genuine?
But they claim they don't have side effects. But I tell them they don't have effects also.
No, they have side effects.
They have very
Many of them have got renal side effects.
My observation is there's something in their medicine that makes these people feel euphoric. Second thing is we are trained to tell facts to patient. We don't hide facts. If somebody is having malignancy, I say it's malignancy. You have evidence, you say yes, now I have evidence, it is malignancy. They will ask us for longevity, outcome, prognosis. You kind of tell them the most polite way. You tell them, no matter how bad the news is, you tell them the bad news. At least somebody in the family. But the other systems of medicine, they don't talk about prognosis. Okay, that hope is what keeps these people going back to them. Allah, I don't solve that part of it.
No psychotherapist.
And these people. Sorry, bad image, but if you are able to see, he's got the step on his head. Okay, so coming back to our primary topic, symptoms. Now, when you open an index in any onco book or any oncological website, there are these many cancers. There are another 4 or 5 in the bottom that I couldn't take a screenshot of. Okay. So how do you remember symptoms for so many cancers? You literally can't. Okay. So that is where I'm going to take help from Madam's slides. She had the incidence of cancers in male women in global incidence. So you just go on to that, sir, because even as an oncologist, no, me or Madam or Dr. Subramaniam, if we are seeing about 30 cancer patients a day, out of them at least 10 will be breast cancer. Another 8 to 10 will be some gynec cancer. 3 or 4 head and neck cancer. The rest is only that 7 of the 30, sir.
So when do it looks like men don't
Men have their share of trouble, sir. Prostate is there, colorectal is there.
50% breast cancer, 25% uterine cancer.
The incidence, this is the average incidence. Okay? See, those incidences there, incidence is a good number, but they are in different phases of treatment. So when you take an OP census, no, not that the calculation of incidence is in different way, but OP census is different. I said head and neck cancer, majority of them are men only. Okay, all the other cancers, majority of them are men. So when you take the average, about 12, 13 will be men, 17, 18 will be women. Okay, now the census might be different for madam. Census might be different for me. It might be different in a medical oncology. It will vary. Okay, for example, you will say, boss, inniki ellame breast case da boss. I gave chemotherapy for 18 patients today, all 18 are breast cases or ovary cases. Man will have good chunk of head and neck. Patients will gynec and head and neck. Patients that keep coming. For me, it will be majority will be colorectal. Colorectal. Second will be breast. Breast will be there. Breast is like, for us, I shouldn't say this, but breast is something that we see every day. It's like appendectomy for a general surgeon. Meaning, it is there. Be it Saturday, Sunday, Monday, there is a breast case every day. Incidence wise, I said, not ease of surgery or simplicity of the disease. The list, it is always there.
It's a craze for people to do robotic surgery. How good it is?
It's good in good hands, sir. It's good in good hands for selective tumors. Selective tumors, because the magnification is excellent. Your precision is excellent. Okay, no matter how old you are, even if your hands are trembling, the robo won't tremble inside. First, what we need to understand is, robo doesn't mean that the robo is performing the surgery. It's just like driving a remote control car. You are the operating surgeon. The robo only precises your steps. It's not even a guide. It only precises your steps. There are programs being created now where it will guide you, but at the time being, you're only driving a remote control car. You're only driving a remote control robo. Okay? For some surgeries, it is excellent, the best. Open surgery can't even be closer to that. Laparoscopic surgery is 50% as good as robotic. Your prostate, esophagus, rectum, endometrium, excellent. Because you're able to see the nerves twig by twig and save the nerve. Your incidence of bladder issues, rectum issues have come down drastically after that. But in good hands, well experienced hands, formally trained hands. Not everybody. Just because somebody has a mission doesn't mean they can do an excellent job. Okay. But things are changing, sir. Very soon, lot of, you'll be surprised. Last month alone, Hyderabad purchased, last 3 months, within 3 months, Hyderabad purchased 16 robots. So very soon it's going to take over laparoscopy. Laparoscopy is going to become, laparoscopy is going to move to the suburbs and the rural areas. Then it may disappear. Trichy is having a robot. Now, they're doing robotics, oncosurgeries. Trichy has one. Salem is also going to purchase one. Our government hospital, Omandora has one. Roypet is going to purchase one soon. So, excellent. Private medical colleges, Savita is having one. Ramachandra is going to purchase one soon. Rela has 3 robots. Rela has 3 robots. They are having 3 Da Vinci. Now Rela sir wants to purchase one more CMR. They have work for that. It's very good, sir. So getting back to our topic. So this same Globocan thing that ma'am had showed, incidence of cancers. I'm showing you this because what we need to know is the symptoms of common cancers alone. Okay? Rare cancers, how do you pick up if somebody has a cancer or not? What are the things? Common presentations, common symptoms, yes. But uncommon, what do you look for? This is the statistics for male, for women. In general, one of these symptoms are there, you can be sure something, this at least, even if he is not having cancer, at least you should think that this guy needs an evaluation, further evaluation. So, loss of well-being, loss of appetite, significant loss of weight, All these in the middle to old age person. Any lumps, bumps, masses that have not regressed or that have not been paid attention to, non-healing wounds, any observable deformity, long-standing symptoms that have not got relieved with or without medications. Now, I have not mentioned pain anywhere here. I wanted to pay attention to that. I have not mentioned pain anywhere here. By which I mean, a lot of them can be painless. That is why our patients fall back. So when they have a lot of patients in head and neck tumors or pelvic tumors, when they develop pain, it means they have gone beyond locally advanced stage. Early stages, they don't have pain.
What about
Only
bleeding? You
investigation.
have not mentioned, no?
Yeah,
Bleeding.
bleeding are all regular symptoms.
Okay.
So these are the uncommon symptoms that, bleeding patient will come for bleeding. So these are symptoms that patients
They
usually
don't
ignore.
have.
Yeah,
They
patients
What
usually
is the
ignore.
only investigation for to find out what is the cause?
One
There
investigation.
is no one investigation. Unfortunately, including PET. PET is a double-edged sword, sir. PET is a double-edged sword. You think you are showing the pointed end to your enemy, other pointed end is in your hand, or it will be cutting your hand, you won't know. Okay? PET is an excellent investigation, provided you should know how to use it. It's like having a nuclear missile. You should know when and where to fire it. If not, you'll destroy the whole world. So let's go to the common cancers that we need to deal with. So most of these symptoms, all of us know. Lung cancer, cough, loss of appetite, body pain, breathlessness, breathing difficulty, all those things, everything is there. But have you ever seen somebody with periorbital edema with a lung cancer? We've seen patients. We've seen patients with all those Horner's syndrome kind of syndrome, metastasis somewhere, Horner's syndrome, patients will get. So you go back and evaluate the patient's lung cancer. So these are things you need to look into. Somebody comes with a swollen eye, our thoughts are always, cardiac, renal and all those things. But in other ways, okay, gentlemen, if all that should be ruled out, so you should not ignore all those things. But second or third visit, when the patient comes back and okay, all those things are okay, then you start thinking of the unusual things. Prostate cancer. So we all know symptoms of benign prostatic hypertrophy. Prostate cancer is a very misleading disease. Because we think, okay, prostate cancer patients will come with symptoms of benign prostatic hypertrophy. Unfortunately, they don't. Okay, very rarely only patients will have symptoms of BPH. They will have prostatomegaly. Okay, somewhere one foci will be there. You do a core needle, you will find malignancy. But otherwise, majority of the patients, you ask ma'am, you ask Suhail, they'll come with bony pains only, back pain, I'm not able to walk, weakness, lower limb weakness, some symptom like that only, majority of them. Or they're picked up in master health checkup, which again is a double-edged sword. Okay, now the management protocols of prostatic cancer have changed. Who do we do? A PSA have changed. How important is doing a PSA in a certain age group has changed. What is the significant cutoff value for PSA? All these things have changed in the last 4 or 5 years. Okay, and the age of doing a serum PSA has also, as a routine in master health checkup, has also increased now. Though most of us do, right? We only do it, ages over 60, not less than that, because there will be there are a lot of reasons why a PSA can increase even in the absence of malignancy. So we need to be sure about that. Not every increased PSA is sensitive of malignancy. For example, if your normal cutoff is 4, if somebody has 5, you don't need to run around thinking it's a malignancy. Look for other reasons of elevated PSA, evaluate the patient well, and then before you break the news, make sure you're actually telling him the right thing.
Due to hormones,
Infection.
due to hormones
Sorry, ma'am?
elevated PSA.
PSA, yeah.
Due to testosterone increased.
Yes, but more common than that, ma'am. Rectal examination, catheterization, infection, recent passage of stone, all these things can cause a transient elevation of PSA, which we mistake as a malignancy.
Okay. Infections.
Infections, yes. Most common. Breast cancer. We all know the most common symptoms of breast cancer. We have what are the eight? What do you think are the atypical symptoms of breast cancer? Anybody has come across atypical symptoms of breast cancer?
So my sister of nearly for 2 to 3 months. My sister-in-law. We investigated everything. We gave her medicine and then we took her for we want to rule out TB, sir.
Yes.
Then they did pipette.
Yeah. So lung mets, brain mets. I have seen patients where the first symptom of a breast cancer was giddiness, loss of consciousness. Evaluated, found to have brain met from a very small breast nodule, 1 centimeter breast lesion, triple negative breast cancer. Her symptom of presentation was a brain met.
For her it was 4 centimeters. Now radical mastectomy done, axillary clearance.
We have seen patients with jaundice as the presenting symptom for breast cancer. See, what happens is not that all tumors are small, but sometimes you tend to miss out. Even women tend to miss out because the breast density varies from person to person. One. Second thing is through their lifetime, because of hormonal changes during periods, a lot of women would have experienced lumpy breasts. So they mistake that to just be another lump, a hormonal change. But what you should understand is these things, be it ovary, be it an ovarian cyst, be it a breast lump, anything happening in the post-menopausal age, do not ignore it. There is no business for a cyst, for a newly found cyst in the ovary or a newly developed breast lump beyond the post-menopausal period. If something like that happens, please pay attention to that.
Skin irritation means what kind of irritation?
Just eczema. That's the most common differential diagnosis people say, ma'am. Nipple distress. There is a certain entity called Page's disease of nipple. So we spoke about these unusual symptoms. Cervical cancer. We all know the most common symptoms of cervical cancer: bleeding PV, vaginal discharge, all those things, postcoital bleed, all those things. Can somebody mention one atypical symptom of a cervical cancer?
Back pain.
Yeah. So this is one example. I'll tell you this. This is interesting. So there's a 58-year-old lady, post-menopausal, had history of bleeding 3 months before she presented to me. Okay, fine. She refused to see anybody. That symptom settled, but she started developing low backache shortly. That started annoying her. She went to an orthopedician. Orthopedician did an MRI spine. MRI spine covered the pelvis also. There they found a cervical lesion. So the 3 months back, the symptom that she had of cervical, that bleeding PV, was a cervical malignancy. The bleeding resolved, but it started causing other kind of troubles. Ovarian cancer. This is very, very, very notorious. People often mistake it and reject the symptoms as being very non-specific. Majority of ovarian cancers only present with non-specific symptoms because this organ doesn't open to the exterior. Unlike your colorectum or your endometrium, it never opens to the exterior. They only have atypical symptoms. Okay, digestive issues, bloating, constipation, difficulty in passing urine. So these are the kind of patients that we always come across. Endometrial cancer, thankfully, ma'am will also agree, all of them come in very early stage because all of them have bleeding. Majority of them at least. People who ignore, that category is different. We're not even talking about them. They will come in stage 3, stage 4 only. But majority come early. Okay. Most common symptoms, bleeding PV, post-menopausal women, don't ignore it even if it's one episode only. Okay. Colorectal cancer, again usual thing. Tenesmus, most people discard the symptoms thinking it's either hemorrhoids or constipation. Lot of doctors have discarded symptoms and ended up becoming, recently one of my friend's dad is a doctor. He was diagnosed to have CA rectum. He had symptoms for 3-4 months. He just ignored it. So here again, doctors are the worst patients. So, situation. Stomach cancer, yes, again, most people, today's lifestyle, nobody pays attention to what they eat, how they eat, when they eat. This end of, where they eat, exactly, where they eat also. Okay, so ends up with this. This is again is a very common thing. All these things are very common. We see this every day. So this is something you need to hear, because not very common do you see these patients. You see these symptoms very commonly. Okay, sometimes you pick them up, sometimes they go elsewhere and they get picked up. These are all very symptoms that you will see every day in your OP. Out of 80 patients, at least 10 or 12 patients will have these symptoms. Okay, so that is where you have to use your clinical acumen. Bimodal age distribution, either young age or older age. Look for other constitutional symptoms. See how long the patients have been having symptoms. Please examine the lymph nodes. See if you can pick up something. Night sweats, fever, swelling of the face and the neck because of swellings in the neck, excessive sweating at night, unexpected weight loss, loss of appetite, breathing issues because of hilar nodes or whatever be the reason, feeling of weakness. Lymphomas you don't get to see very common, but if it comes, please do not ignore it, because these guys can actually be treated and cured.
Yes.
These guys can be cured, so there's no point in missing them. Leukemias, you have different symptoms depending on what age group they come in. Bimodal distribution again, younger age group, older age group. Symptoms almost the same: fatigue, bleeding, headache. Again here, there's one patient that I'd like to throw a light on. Very interesting. 70-year-old male. His presenting complaint was fatigue, tiredness, fever for 2 weeks duration. So this gentleman has been going around doctors for 6 months. Again, the next problem is he was inconsistent with visiting doctors. We'll go to one person once, then second person, then third person, fourth person, and every person he met was all highest level specialists in the city. Oncologist, hematologist, surgeon, physician, all top-notch people only in the city. Only problem was they were all very busy people. I always tell people, it's very important to communicate with your doctor. Take the appropriate papers, because sometimes you're in a bit of a run. Okay, so if all the facts not presented, you may not even think of things like that. Okay, so this guy had all the papers. Only thing is he had it all arranged in separate files. So just that somebody had to sit down and go through all the files, you could actually put the puzzles together. Everything was done by everybody. Everybody has done their sort of the job. Just that the compiling thing nobody did. So this guy was going around that for 4 months. He was found to have a leukemia. And in between, he developed some colitis. Somebody had done a PET scan, they said there's some cecal tumor. So he was being planned for dual malignancy. One side leukemia going on, the other side the cecal malignancy going on. Cecal malignancy turned out to be Crohn's, so that part is sorted out for him. Skin tumors, again something that we overlook most of the times. I mean, we don't get patients like this. Rarely, because most of them go to, they are all mostly in the peripheries or in some small centers. Invariably, somebody excises it, thinking it's nothing, somebody excises it, then it turns out to malignancy, then straight from there to the oncologist only. Okay, so any change in this all of us know, asymmetry, border, color, diameter, revolution, where there's curving or outgrowing of the skin lesion. Look at this. Another interesting thing, one 65-year-old gentleman came with a small wart here in the infraorbital region, excised by somebody. They said it's probably a skin adnexal tumor. Immunohistochemistry done, turned out to be metastatic adenocarcinoma. Now, okay, maybe it's from one of the sweat glands or something. Then they said no, something is not okay. Patient was on a tight budget, so somebody offered to get a PET scan done for the patient free of cost. So PET scan showed a tumor in the tail of the pancreas. So that was his primary. Pancreatic tail lesions never show any symptoms. They show symptoms like this only. They metastasize elsewhere and they show symptoms.
Even back pain.
That man didn't have, because the body of the pancreas will have back pain, ma'am. Tail of pancreas, those lesions kind of grow into the spleen, so they don't have much. If it grows to a large size, then they have some gastric symptoms. Otherwise, mostly they don't have symptoms. Okay, sarcomas, yes, we know. Again, we've had patients who are young age, pathological fractures, non-healing fractures, finally turned out to be sarcomas, bone tumors. Soft tissue tumors, people ignore. Most commonly, people who have recently started going to the gym. They'll say, I thought my calf was growing, I thought I was doing too much of leg workout. And finally you look at that day, calf will be asymmetrical. One side it will be 18 centimeters, one side will be 12 centimeters. This calf muscle. Then you evaluate, do an MRI, then you find out a sarcoma. So these kind of things you will come across. You just have to have an open mind. This is important because again, any peripheral tumors, tumors in the periphery, you have the possibility of salvaging the patient's limb. Long gone are the days of amputations. Now you don't amputate people just because they are peripheral tumors. Those days are gone. Now we only do it in metastatic setting or somebody else's heroic mishap. You do amputation for somebody else's heroic mishap. Either improperly done surgery or incomplete done surgery, or thinking it was something small and operating and something else coming out as a report. Only those patients end up in amputations. We don't do amputations. This is the era of limb salvage. So I have thrown light on the most common cancers, and I hope I've made myself clear with some interesting facts. I know we talked very much man's level, but I just hope I gave some carry-home points.
It is equally interesting. It's a lot of real-life situations. Actually, this is very broad, no? It's difficult to...
Yeah, that's why I didn't touch on the surgeries, man. Probably we'll have another meeting where I can talk about the surgeries or novel therapies that we do. Because every tumor that I spoke on, things have changed several folds in the last 10 years. Now it's all about conservatism. Just like how ma'am said, we don't operate on the laryngeal cancers directly anymore, sir. We send it to madam only. We send it to madam to sir. It's only in salvage situations or very advanced like cartilage involvement that comes to us directly. It's always voice preservation protocol, urinary bladder preservation protocol. We don't chop off the bladder anymore directly.
Once again, I want the same question. Is cancer hereditary?
Yes, sir. Cancer is hereditary. There are hereditary cancers. You have to know. Yes. Take this home. There are hereditary cancers, but they are a very small proportion. They're a small proportion. You have to identify these people. You have to screen the family. You can prevent cancer in the next generations by identifying them early. Either prevent or treat them and get them in early stages. There are a good chunk of hereditary cancers. There are about 8 or 10, 2 or 3 syndromes. There are actually a lot of syndromes, but most commonly 2 or 3 syndromes pertaining to breast cancers, colorectal cancers, ovarian cancers, endometrial cancers. Yes, all of these are the hereditary cancers. Sarcomas. You can, if you sit and talk to one of these people, you give them some pressure, they will give a history. Yes, somebody in this family had cancer 2 generations back. Yes, 1 generation back, this relative had cancer. That patient died at a younger age, so I didn't remember that it wasn't pertinent history. Yes, hereditary cancers are there, sir. It's a reality. Very soon, I think, as ma'am said, I think those clinics will come. Hereditary cancer clinics will come.
We are having hereditary cancer clinics. Yes, younger patients are less than 40 and younger to that, when we see breast cancers all that in the age group of 24 and all that, they are sent to hereditary cancer clinic for screening, for blood evaluation, and the family is also counseled and screened. It's done.
We see so many cancers now in the last 2 decades. Is it because lifestyle changes, or is it because of
People are living.
or is it because we've got more of investigation facilities?
It's a multifactorial thing, ma'am. Etiology wise, why so many cancer cases are detected, that's a multifactorial thing. You cannot put the blame on just one thing alone. Lifestyle or food, or it's a multifactorial thing. It's everything multifactorial.
Body.
Yes, we are picking up cancers at earlier rates now because facilities are available everywhere, investigations are available everywhere. There are so many specialists, the number of doctors have also increased. So somebody other, we're all doing a fair enough job. Next thing is, that generation that hesitates to go to the hospital is gone. Now everybody wants to go to the hospital to find out what is going wrong. Next, the current generation, everybody has insurance covered one way or the other. So they're okay with coming to hospital, spending a little money to find out what is going wrong with them. Okay. Now everybody, even parents are included in insurance. Even if it's just a small amount, it's still a big help for them. Rather than paying the entire bill, even if 20-30% is covered, that's still a help. Okay. So good insurance coverages, good government schemes are there. So if I operate on 8 patients a week, at least 2 to 3 of them are under the government.
The Chief Minister's
scheme is very, very, very helpful. Very helpful.
But do you get the money from Chief Minister?
No, sir, it's see, all of us at some point, no, sir, beyond a certain age and time, no, we want to contribute to the community one way or the other. So we take it this way, sir. We take it this way. Okay. Instead of every person has their own perspective, but instead of paying something out of my pocket, if I'm able to do a service, even if I pay something out of my pocket, I think at that point that service will not equate to what I'm doing. I pay 30,000 for a patient's treatment. 30,000 is nothing these days for any treatment. I'd rather do that for a patient in CM scheme. I'd be doing work for 50,000.
But CM scheme, the government hospitals are getting money from that. They are improving the.
No comments on that.
No, I was working in a government hospital.
Both
So
ways, yes, advantages.
No, they are improving it. Government hospitals
they are
are
getting medicines, they are getting their equipments for the.
they're doing a good job. They're doing an excellent job.
You know, the cervical cancer, is it because of the hygiene? Has it got anything to do with the hygiene? Because once upon a time there was.
Definitely yes. Hygiene, immunity, and HPV.
Yeah.
Human papillomavirus. 99% of cervical cancer, squamous cell carcinomas are associated with HPV. Preventable cause, vaccinations are available. I think it's an onus on all of us to impart the knowledge to the next generation.
Thank you, Dr. Suhail Ahmed, for your wonderful presentation. In fact, this case scenario was an eye-opener for most of the general practitioners. He discussed around 10 to 12 case scenarios. It's very useful.